Now the timeline, see, right from the early 60s, 50s, 60s, there have been efforts to find out new biomarkers, molecules, to optimize therapy in myocardial infarction and in cardiac ischemia. So right now, right through AST, LDH, CKMB, troponins, now we are right now in 2020s in high sensitivity troponin tests. Now, what is the difference between normal troponin and high sensitivity troponin? The terminology reflects the analytical characteristics of the assay and not a difference in the cardiac troponin measured. So basically, it's a troponin that's being measured. It's that this assay is different and it's able to pick up very, very low levels of troponin. So you can pick up an MI or an ischemic event much before than what we can do with a plain troponin. Now, why to use these assays? It's increasing sensitivity of cardiac troponin assays enable detection of smaller areas of necrosis. So when an MI or an ischemic event starts, when a small area of myocardium starts necrosing, we get this test positive. It optimizes the negative predictive value, and high sensitivity troponin allows for a more rapid triage because the lab turnaround time for this test is only 1 hour compared to regular troponin. And improves the discrimination of low-level troponin I concentrations at present as well as over time. For early presenters, low-end precision allows early detection of significant changes in troponin I concentrations, which may not have exceeded the 99th percentile limit. So what happens is, now the threshold values have been reduced with high-sensitivity troponin, and before the regular troponin test turns positive, this test will show up results, which can indicate, yes, this patient is going in for a problem. Now, serial sampling is recommended. They may be shortened with a high-sensitivity troponin assay based on published guidelines. Basically, when a patient comes in with chest pain, the recommendation is forget about CPKMB, forget about troponin I, you get a HS troponin I done. And then after 2 hours, if it's above the threshold, you're facing a problem. And after 2 hours, if it's going up, then you're sure. And if all this happens before the regular troponin becomes positive. You can see here in this chart, the high-sensitivity troponins and the above, and the regular standard troponin is given below. So within 2 hours, you can see that the high-sensitivity troponin, whether it's troponin I or troponin T, has increased to a level that is detectable by these assays. High-sensitivity troponin has significantly greater early sensitivity, 95%. 95% is very rare for any of the tests that we have for any medical disease, and a negative predictive value for the diagnosis of AMI. So this is a highly sensitive test, but it comes at the cost of specificity. It's only 80% specificity and positive predictive value, which may help enable to rule in and out AMI in patients with chest pain. And if the high-sensitivity troponin I is positive, despite the normal troponin being negative, these patients also are associated with increased non-fatal MI or death during follow-up. So any level above threshold is significant. Now, if you see this, the high sensitivity assays that are in the left-hand corner there, it starts rising within 2 hours, within less than 2 hours, and it reaches threshold very far, within 3 hours, threshold for positivity. While the regular troponins will take some more time, 3 to 6 hours it takes. So if this becomes positive earlier, you can initiate management earlier and help prognosticate the patient. Now, this is a quantitative, it's a quantitative test. You use a baseline, you see this, 0.014 is the cutoff, below which it can detect up to 0.004. 0.005 is healthy. 0.01 you may indicate stable angina, cardiac failure, LVH, subclinical heart disease. That's why the positive predictive value is less. And 0.05 nanograms, micro AMI, 0.1 small AMI, 1 nanogram per liter, medium AMI, and more than 10 is a large AMI. So you can get this within a couple of hours, within an hour of sending the blood sample to the laboratory. The point-of-care tests are not as sensitive as the lab tests in this particular case, in this particular assay. So early diagnosis of MI reduces time to rule in and rule out MI, improves clinical accuracy of testing because sensitivity is very high. Laboratory turnaround time is only less than 60 minutes, which is much lesser than a regular troponin. It improves, obviously, so when you start treatment early, it improves patient outcomes, improves turnaround time of patients admitted for chest pain to the ED. So this is very important for economic reasons, in the sense that most hospitals, especially in the West, they're always crowded. They want to move out patients who are not, who do not need treatment, though they're having chest pain. So they use HS troponin to do the needful. Now the flip side, like I said, the specificity is low. And that is where it's a small hindrance, where you have to keep in mind the clinical picture of the patient before interpreting the results. So other clinical conditions that can cause high sensitivity troponin elevation is, there's a big list: heart failure, myocarditis, contusion of chest, hypertensive crisis, CVA. Basically any disease, any sepsis can cause a rise in high sensitivity troponins. And all this, the cause of rise in these situations is that there is myocardial injury just short of myocardial infarction. So the management strategies will be different. The reason for this is coronary microvascular dysfunction, increased wall stress, and decreased subendocardial coronary blood flow. So because of this, the specificity of this test is low. And that is the flip side, and that is where we have to use our clinical sense to make a decision on the importance of the reports. So what the difference between myocardial injury and myocardial infarction? The term acute MI should be used when there is an acute, this includes non-ST elevation MI, mind you. Acute myocardial injury with clinical evidence. So you must support the lab findings with clinical evidence, symptoms, ECG imaging of acute myocardial ischemia with detection of a rise and fall. So serial measurements every 2 hours is very important. If you have a rise within 2 hours or the next 2 hours, 2 hours time intervals, then you are sure that this is a cardiac event and not a non-specific myocardial injury. The term myocardial injury should be used when there's evidence of elevated cardiac troponin, HS troponins, with at least one value above 99 percentile and no rise and fall. So a patient comes with chest pain, he has a value above threshold. You repeat it after 2 hours, the value does not rise, then you know that this is not an ischemic event. It may be a non-specific myocarditis or any other thing that causes myocardial injury. So serial sampling is to observe the rise and fall above thresholds is a must. Consistent with clinical symptoms of ischemic event and ECG changes, if the initial result is below threshold, a change of at least 50% is significant. So the first, on admission, the levels are below threshold. After 2 hours, if there is an increase in 50%, by 50%, even if it does not still reach the threshold, it is significant for ischemia. If the initial result is above threshold, just a change of 20% is significant. So you have a threshold value, above threshold value when the patient comes in. After 2 hours, you do a repeat and it's more than 20% previous value, then again, you're dealing with ischemia. The second sample is to be collected 2 hours after first sample. So 2 hourly intervals. Now these are all, protocols are just being formed. So as of now, 2 hours intervals between 2 tests are recommended. Now what are the thresholds? Normal females have less than 14 nanograms per liter. Normal males have less than 22. But to ensure that MI is missed, the diagnostic thresholds are 10 nanogram for females and 15 nanogram for males. Here again, there is gender-specific thresholds, which is not there in our regular, whether it's regular standard troponin, or in the CPKMBs. Now, this is a flow chart. Patient comes on presentation. You do a high-sensitivity troponin. If it's more than 100, you know your 100 nanograms, you know you're dealing with an MI, so you don't have to go further as far as testing is concerned. You manage the patient. If it is between 15 to 100, then you have to repeat the sample. Here it says, this thing says 6 hours, but the general recommendation now, this is a slightly old flow chart, is 2 hours. After 2 hours, you repeat, and if it is more than 20% rise, then you know you're dealing with this thing. And in 15 nanogram, if it's less than 15, you can repeat once more and still remains below threshold, then it is non-cardiac. Now, points to remember, high-sensitivity troponin assays are defined by analytical characteristics. It's not different troponin, it's the same troponin. Assay is different. It's a quantitative test. It helps us prognosticate. It's very useful in suspected non-ST elevation MI patients, because ST elevation MI, you don't need any blood tests to, if your ST is elevated, you don't need blood test to corroborate. You can go ahead with treatment. Acute MI can be safely ruled out within 3 hours. Serial changes in troponins are essential. So serial changes are essential. At every 2 hours you have to take. And majority of the cardiac troponin point of care, now in this high sensitive troponins, point of care tests are not available and not accurate, not sensitive. So you'll have to rely on lab reports. Thank you.